in the urine output, and at this time on evaluation his serum creatinine was found to be around 1.5 milligram per deciliter. At this time, no urine analysis reports are available or the patient cannot recall them. And at this time, patient has been advised to visit a nephrologist. He recalls that his oral medication were changed from previous medication, and he was also told that few blood and urine tests need to be done for his kidney problem. Again, patient was lost to follow-up. Over the next 3 years, he visited hospital a few times with intermittent episodes of swelling of feet. He recalls there is a rise in serum creatinine somewhere around 3 milligram per deciliter, and as far as patient can recall, he says that he was complying to the medication that has been advised. In March 2024, he developed blurring of vision for distant vision in both the eyes, and at this time he visited an ophthalmologist and he was evaluated and told to have changes in the retina in both eyes due to diabetes. At this time he was also detected to have high blood pressure and he was started on antihypertensive medication. It was at this time that he underwent checkup for both his urine and his kidney function, and he was told to have protein leakage in urine. And his kidney function, at that time he remembers that the creatinine to be around 4 milligram per deciliter. His blood glucose level at this time was still high and he was advised for insulin initiation by the treating doctor and was told to that he has a kidney problem, most likely due to diabetes. He recalls that he underwent laser therapy in each eye. The last setting was done in December 2024. At this time, other than blurring of vision and some swelling of feet, he did not have any other complaints. He continued to take insulin and other medications which he was prescribed for his kidney disease. In January 2025, he had insidious onset, gradually progressive swelling which has started from his feet and extended gradually to the whole body. He was admitted to his local area hospital and treated with some IV medication, following which he had symptomatic improvement and his urine output increased. He was told to have worsening of kidney function and was explained the possibility that he might require dialysis in the near future. It was in October 2025 that patient presented to Max Vaishali for the first time in the nephrology OPD with complaint of generalized weakness, body swelling, decreased urine output and shortness of breath on exertion. At this time, he also had loss of appetite, nausea, and on OPD basis evaluation, the serum creatinine was found to be around 6 to 6.5 milligram per deciliter. Patient was admitted, treated with intravenous medication and was found to have a low hemoglobin. He was started on weekly injection for the same. At this time only he was advised dialysis initiation, but he was not willing, so he was continued on medical management and was discharged on oral medication and was told to follow up in OPD, but again the patient lost to follow up. Next, in January 2026, patient again presented to emergency with complaint of generalized body swelling, shortness of breath, decreased urine output. Patient was hospitalized, but despite medical treatment, his shortness of breath worsened and patient was initiated on hemodialysis via right side IGV-HD catheter on 27th of January 2026. After above treatment, his swelling subsided, orthopnea improved, and later he was discharged on twice per week maintenance hemodialysis and he has been advised for AV fistula formation. On 17th of February 2026, patient presented to Max Nephrology OPD for his journal routine health checkup. On the negative history, patient gives no history of discoloration of urine, fever, rash, any photosensitivity, oral ulceration, joint pain, weight loss, night sweat, history of recurrent UTI. No history of alternative or complementary medication intake. Past history, patient has known case for diabetes from past 16 years, hypertension from past 2 years, no history of stroke, claudication, no prior history of chest pain, no history of change in the bowel and the bladder habits, no major history in past. Personal history, he is married, he is a teacher by occupation, he consumes mixed diet, there is no history of addiction, his bowel and bladder habits are regular. Family history, his mother had diabetes and she was being managed with one oral anti-diabetic medication. The name of the medication patient cannot recall. No comorbidity was noted in the father and no kidney disease was documented in the family also. Sir, should I continue with the summary?
Yes, I would want actually that this is a patient who has got chronic kidney disease related to diabetes.
Most likely, sir.
So tell me, how do patients of chronic kidney disease, see when you see them in the outpatient, do you go to the outpatients with your consultants or most of you are inpatients? How many of you go to the outpatient? Have you been to the outpatients with do you see patients in the OPD or not? You see patients and then you present it to the consultant and all that, say new patients and all that. So how do patients of chronic kidney disease by and large present? Say advanced kidney disease, creatinine 5, 6. Many times they won't even accept that they have got chronic kidney disease. They would not believe the reports. Creatinines of 8, no symptoms. Isn't it? They are anemic. Hemoglobins of 6, but no symptoms. Urine output good. No edema. And you tell them that your kidney function is 5%, 10%, they find it very difficult. Isn't it? They don't accept this diagnosis. They say, कुछ गलती कर रहा है डॉक्टर, कुछ आज शायद बीवी के साथ झगड़ा कराया या जो भी है, कुछ ठीक नहीं है, कुछ गलत है. So they don't trust. Have you wondered as to why that happens? Can you tell me why that happens? That patient has advanced kidney disease and and he or she says that there is no symptoms and they don't have. In fact, you do examine them, they look good, except for pallor, that they are anemic. They don't give you any symptoms. And he says the urine output is good. I pass 2 liters of urine. You tell me my kidney function is 5%. How do I believe you? I have no symptoms. No nausea. My appetite is okay. Not that bad. So, have you ever wondered why would advanced kidney disease still? No, isn't it? That amazes you actually. Why is it kidney is supposed to be the organ which maintains the milieu interior, is an extremely important organ for that. Kidney dysfunction of even small amount should cause disturbance in the body, but it doesn't. So why would that happen?
So depending on the underlying cause, whether it is CGN or CIN?
No, even if it is whatever the cause. CGN happened, say, burnt out CGN, the picture is not very different.
In diabetes?
So in diabetes, it may be slightly because of massive proteinuria. And sometimes edema occurs as has happened in this patient. That is a significant edema. But you look at all other hypertension, even glomerulonephritis. 10 years back, glomerulonephritis, they progress. Somebody you treated as crescentic glomerulonephritis, you treated, they got better, but then kidney disease progresses. And by the time they are end-stage kidney disease, they are very, very similar. They are not very different. You do the ultrasounds, kidneys are small, bilaterally small. They could be interstitial nephritis, they could be glomerulonephritis. Past history of nephritis will tell you that is glomerulonephritis. So, and even many diabetics also may not necessarily present all the time with edema only. So it will depend on. So we'll come to that also, who are the patients who will develop edema. But tell me, why is it that patients of advanced kidney disease don't have? Have you? Anyone? You
so
tell
most
me.
likely the patient have a picture in their mind that if I will have a kidney disease, I would...
No, I'm not saying with what the patient thinks or what the patient has. But why is it that you don't find much on examination? Why is it that patients are able to continue to do well and they don't believe? Yes?
So residual renal function and progressive detection.
Residual renal function. What is residual renal function? What is, how do you define residual renal function? What is?
The CKD patient is passing the adequate amount of urine.
Yeah, so why would the overall function has gone down to 5%. So what is residual is 5%. But why is it that you have 95% of the kidney gone, but still not much that you find on examination? You do the electrolytes except for urea, creatinine, sodium is good, potassium is good in vast majority of patients of kidney disease, unless they are on drugs which you have given to increase potassium or something, but otherwise, they don't. In the OPD I see everyday patients, they look at me and then probably feel, ये क्या बता रहा है, मेरी 5% बता रहा हूँ, ये मुझे समझ नहीं आ रही है. So there is disbelief in them.
Gradually progressive course of disease.
No, but what happens? So what happens with glomerular hypertrophy?
Electron filtration.
Hyperfiltration, the glomeruli try to preserve and accommodate that by glomerular hyperfiltration and hypertrophy.
Okay, what does that do?
But it will preserve the GFR for initial few years might be, but later it will cause remodeling and will cause sclerosis eventually.
So that's the cause of progressive kidney disease. That why does kidney disease, even if diabetes is normal or glomerulonephritis has recovered, you had a post-infectious glomerulonephritis, infection is gone, there isn't much of an activity as such, but kidney disease still progresses. So kidney disease is a progressive disease. Even if the initial cause which caused it has disappeared now, but kidney disease progresses by itself. And that is the mechanism of it, and which Brenner gave, that there is initial hyperfiltration and all that. Okay? So anyone who can tell me a better reason why kidney disease? No, that's the reason I asked her to present chronic kidney disease. I think you'll not find it in the books, but you will have to make it out as to what it was. She was interested in presenting pregnancy and kidney disease. That's what she had prepared, I guess. Then I wanted that there's something. Pregnancy is also one of my favorite topics, but I thought let me talk about something which is usually not talked about, and that's chronic kidney disease. Huh?
Physically preserved for the time, like at the time of initial presentation, they might be physically preserved. They have a good muscle mass.
No, India में कहाँ है यार muscle mass? तो India में तो by and large patients at, what's the general prevalence of malnutrition in the Indian population? What's it? What percentage of Indian population, normal population?
Sir, a diabetic patient.
No, not diabetic. I'm talking general population. What's the prevalence of?
52 to 6.
Yeah, 50% of people have some degree of malnutrition, severe malnutrition to moderate to severe malnutrition in about 25 to 30% of normal population. Malnourished. We have obesity on the other end, that's also there, but by and large patients. So in India, by and large, people are not very well preserved. There are few patients now, younger generation and all, who are into gyms and take high protein diets and all that is different ball game. But in general, people are malnourished. They're not really initially very well preserved, and that's related predominantly. See, the reason why this happens is that what is the fractional excretion of sodium in patients of kidney disease? क्या होगा?
Then 1%.
So कितना होगा? ज़्यादा होगा, कम होगा, क्या होगा? Patient fractional excretion of patients with kidney disease. What is?
More than 1.
ज़्यादा होगा, कम होगा?
ज़्यादा.
ज़्यादा होगा. कितना होगा?
More than 1.
So ये तो AKI में पढ़ा था आपने, CKD में तो नहीं कोई इसकी. AKI में है कि भाई ATN में more than 1, pre-renal failure में, ठीक है ना, pre-renal failure में ज़्यादा कम होगा, less than 1, and ATN में higher than 1. Fractional excretion of kidney disease में. What's the normal osmolality? सोडियम एक्सक्रीशन कितनी होती है? नॉर्मल 20. सोडियम एक्सक्रीशन कितनी होगी एक इंसान की? कितनी? हाँ
सर, less than 20.
नहीं. What does sodium excretion in kidney in urine tell you? Suppose you do a 24 hours urine sodium.
Concentrating mechanism are.
And what does it tell you?
Concentrating mechanism are affected.
No. What does it tell you?
Distal tubules.
And?
Distal tubules are affected.
नहीं अरे यार आपका अगर मैं 24 आवर्स यूरिन प्रोटीन करूं यूरिन सोडियम करूं तो what will it tell me? It will tell you status of tubules. नहीं तो बड़ा गड़बड़ हो गया. Normal इंसान में तो status of tubules should be good. Your status of tubules has to be good. Why would your tubules be bad? What does it tell me? If I measure somebody's 24 hours urine protein, it tells me how much of sodium are you taking. If you measure 24 hours, the best way of finding out how much of sodium a person is utilizing is by 24 hours urine sodium. Now if you become Anna Hazare and you go on a fast for 3 weeks, no nothing, no pani, nothing, everything to you. So what will happen to your urinary sodium?
That will be low.
It will decrease. It will become, so fractional excretion of sodium is the fraction of sodium excretion related to the creatinine clearance basically. That's the fraction of what creatinine clearance? The sodium is excreted. So sodium excretion is fractional excretion of sodium related to the renal function. So fractional excretion of sodium will be what? Will be very low. Or it will be if you measure 24 hours urine sodium in a normal person. So normal kidney can bring down the urinary sodium when you are fasting to less than 10 milligrams. Now you go to friends party, आप वहाँ पे beer पी रहे हो 24 घंटे, आप binge drinking हो रही है, खाना पीना हो रहा है, you take lot of salt, namkeens and all those. और अगर आपका 24 hours urine उस दिन सोडियम करें तो ये कितना होगा? 200 भी हो सकता, 300 भी हो सकता. Urinary sodium has no normal. If you look at the values of urinary sodium, there are no normal values. The reason being that urinary sodium varies depending on what is your intake. So urinary sodium reflects the extracellular volume actually. If you want to find about the extracellular volume in the body, do the urinary sodium. If the urinary sodium is reasonably high, the extracellular volume would be reasonably good. More than 100, usually a good extracellular volume. Less than 10, volume depletion. That is what it tells you in a normal person, or less. So person who is not drinking or taking anything for last 3 weeks, 4 weeks, like Anna Hazare, then you will become volume depleted and your sodium will go down. So kidney has a huge capacity of, what is the osmolality of the urine normally?
Range to
50 to
1200.
1200. So if it is 50, then what does it tell you?
Diluted urine.
It tells you a dilute urine. Now how will you know whether it is dilute? What is free water clearance and negative free water clearance? कभी पढ़ा सुना आपने? सुना कि नेगेटिव फ्री वाटर क्लियरेंस या फ्री वाटर क्लियरेंस क्या हुआ? हाँ जी, फ्री वाटर क्लियरेंस कभी नहीं सुना? नहीं, फ्री वाटर क्लियरेंस सुना हुआ है, बट एनीवन विल टेल मी व्हाट इज फ्री वाटर क्लियरेंस? पार्डन? चलो, पेशेंट्स ऑफ किडनी डिजीज में व्हाट हैपन्स टू द यूरिन osmolality? In patients of kidney disease, chronic kidney disease, what will be the osmolality of the kidney? Yes? Isostheneuric. So what does isostheneuric means? So same as plasma. What's the plasma osmolality?
It's around
270 to 300. So for calculation purposes, let's take it 300. ठीक है? So 300 is the urinary osmolality and the plasma osmolality, and if it is isostheneuric urea, so it will be. So if you have, what is the normal osmolar load that a human being consumes in an average intake of food and all, average day-to-day intake में कितना osmoles होगा? Food में how many osmoles? So the third year resident bhai, how many osmoles? Normal हिंदुस्तानी खाने में it can vary from food, from obviously American खा रहा तो बहुत ज़्यादा भी हो सकता है, but an average Indian may be an average खाने में 600 milliosmoles. So if you have 600 milliosmoles which have to be excreted, isn't that's what the kidney's function is, that it excretes that osmolar load. And if it is in patients of chronic kidney disease, अगर isosthein urea है तो 600 milliosmoles करना तो कितना यूरिन आउटपुट होगा? नहीं, किडनी डिजीज के मरीज में अगर 600 milliosmoles निकालना है and the urine is isosthein uric, so what will be the volume? मैथमेटिक्स में भी कमजोर, ठीक है, डॉक्टर लोगों का मैथ खराब होता है, बट इतना खराब तो, हाँ जी, अरे नहीं, अरे कितना एग्जैक्ट बताओ मुझे भाई, इट शुड बी मोर नहीं, 2 liters, yes, 2 liters. How did you come to liters? 300 milliosmoles will be excreted in isosthein urea, will be 1 liter, ठीक है ना, milliosmoles per liter. So 300 milliosmoles. So for 600 milliosmoles. So if your urine volume is 2.8 liters and you have 600 milliosmoles and you cross, so what will be the free water? 800 ml. So is it positive or negative? It's an extra water which is other than the osmolar clearance, isn't it? Which is called free water clearance. Other than the osmolar clearance will be so the volume of urine minus the osmolar clearance. Osmolar clearance is urinary osmolality divided by plasma osmolality and the volume of urine. So that will be the osmolar clearance of the urine. So in normal people, you have an osmolality, you can reduce your urine osmolality from 50 to 1200, isn't it? So which would mean that you can pass large amounts of urine. How many urine? If the osmolality is 50 ml, so what is the volume of urine? That 600 ml कितने में हो जाएगा? 600 milliosmoles कितने में निकलेगा? 12 लीटर, ठीक है ना, 12 लीटर में. और अगर 1200 osmolality होगी तो 500. So is 500 important? Can any one of you tell me why is 500 important? किसी चीज़ में नेफ्रोलॉजी में यूज़ होती हो 500 ml. अभी बात हो रही थी acute kidney injury, but oliguria. You define oliguria when the urine output is less than 500, and the definition of acute tubular necrosis or acute renal failure is also oliguria less than 500, and it is based not on any just like a number like ठीक है 500, why not 400? It's related predominantly to the osmoles that you can, the maximal osmolar clearance beyond which you can't have the urine is 1200 milliosmoles. That is the highest capacity. Anyone who tells me which animal has very high urinary osmolality, which can increase urinary osmolality to 2000, 3000, 4000?
Camel, sir, camel.
Desert rats and camels, yes, desert rats, because these are the people who need to conserve water. They need to conserve water because they are in desert rats and all that. So those will be the. So which are the nephrons which do concentration to a greater extent and can? Anatomy भी थोड़ी. Which nephrons? So you have nephrons. Can you tell me where nephrons? So juxtamedullary nephrons, which are because of they have a long loop of Henle. So loop of Henle is where the concentration of the urine or dilution of the urine occurs. So these are the tubules, either the ascending limb of loop of Henle or the distal convoluted tubules, which is predominantly in the, so they have long loops. So they have long loops of Henle. So they are the ones which are doing this. So normal capacity of the kidney. Now what happens when patient of chronic kidney disease? What happens to them? So the number of nephrons, how many nephrons are there in each kidney? 10 lakhs? 1 million. 10 lakhs तो यार आजकल 8वीं के लड़कों को भी पता होगा ये, क्यों जी? है मेरे ख्याल में आजकल बायोलॉजी बुक्स में तो 8वीं 10वीं में होगा. So 1 million in each kidney. So if you have 1 million nephrons, now what happens in chronic kidney disease? So you have nephron loss. So you have nephron loss. You know of an intact nephron hypothesis, which would mean that if the glomerulus of a particular nephron has got sclerosis, the tubule of that nephron will also not function. Or if there is a tubular atrophy in a particular nephron segment, then the glomerulus will not. So when glomeruli or nephrons act, they act in toto, complete. So the glomerulus is good and the rest of the nephron components are also good. So the intact nephron hypothesis is predominantly on that basis, that if a particular part of kidney is damaged, say glomeruli are damaged, maybe a glomerular disease, the nephron of that glomerulus also goes away. So it's based on that theory that so when you have chronic kidney disease which progressively increases, so the nephrons keep on dropping off. So from 1 million they go to. So what will happen to, how does kidney maintain its function? Right? Hyperfiltration. That's what you were talking about, the hyperfiltration. So rest of the glomeruli they go hypertrophy, and there is increase in single nephron glomerular filtration rate. So as the nephron loss occurs, then there is increase in the size of the rest of the glomeruli, and which is its downfall also, which is what you were talking, which is what Brenner had suggested, that this is what will cause progressive glomerular. Now what happens because of this? Because of this increased single nephron glomerular filtration rate, so kidney is able to maintain its overall, the function of kidney is to maintain the internal milieu of the body. So it is able to compensate, and it continues to compensate till its function becomes extremely low, which is fairly advanced kidney disease. And that's the reason. So the fraction, when you have increased glomerular filtration rate in a single nephron, what happens in that nephron? What happens to proximal tubular absorption of sodium?
Increased.
Absorption is low, because whenever the glomerular filtration rate in a particular volume depletion, the glomerular filtration goes down, then the sodium excretion is high. So when there is solute diuresis. Now the same amount of urea which is there in the body, if it was to be processed by 1 million nephrons, now is processed by say 500,000, and then maybe 250,000, and then maybe a few 100,000. So there is greater amount of solute per nephron, and that causes solute diuresis or adaptive natriuresis. So there is increased excretion of sodium which occurs. So absorption of sodium and glucose and many other things obviously are changed because of this. So there is solute diuresis. It doesn't allow, and that's the reason for polyuria in patients of chronic kidney disease. So initial symptoms, if you ask a patient, you don't know when did the chronic kidney disease start. So the symptoms that you ask are usually polyuria or nocturia, isn't it? He may not remember the polyuria as such, but he will remember the nocturia because he has to get up at 4 times. So in early chronic kidney disease, how many times would he get up? Can you guess it?
I think
Everything is mathematical here.
3 to 4 times.
3 to 4 times? How did you say that number? You have to give me a reason for that. Why would you think you will get up 3 to 4 times? You have to, what did you say 3 to 4 times? Why not 6 times? Or why not 1 time? How many times? When the urine is isostheneuric, what happens? He passes same amount of urine during day as well as night. Normally what happens in our normal person? There is usually
Water intake.
More during daytime.
more during daytime. Because of what? Diurnal variation as such, and the intake also. During the daytime your intake is more activity and all that. So there is a diurnal rhythm and that. But when the urine is isostheneuric, chronic kidney disease is not able to do much as far as concentrate. They're maintaining the osmolality at the same level. So if the urine is isostheneuric and it is passing 2 liters of urine, say 2 liters may be the average intake of a person as we talked about, and 2 liters is also the solute that it has to excrete in 2 liters of water. So how much you will pass in the day and how much at night? Equal amount, isn't it? So 1 liter. So if you have to pass 1 liter of urine at night, what's the capacity of bladder? 300 to 400? 300 to 400, isn't it? You get a sensation at about 300 to 400. So if 1 liter has to be passed about, so if he passes urine just before he goes to sleep, he will get probably around 2 times or 3 times the most. Isn't it? 300 ml, 1 liter to be passed at night. So 12, if you say 8 to 8 and then, or 10 to 10 and then 10 to 10, he'll pass around. So he'll get up. So he'll pass the same amount of urine, isn't it? So you can in fact predict if there is nocturia and all in these patients, you can predict from this pathophysiology that you are seeing that you will pass about urine. So nocturia and polyuria is related to solute diuresis because there is increased single nephron glomerular filtration rate and the kidney is trying to compensate. And it will keep on compensating. So the adaptations which occur in a failing nephron is that they are able to maintain this sodium excretion increases, and that's the reason why your patients don't have symptoms, because they are able to maintain their salt and water. And then you tell them also, many of these patients will be hypertensive, you tell them to cut down on the salt intake. Vast majority of patients in India, in addition to you are telling that they reduce their protein intake, overall intake goes down by and large. Their family members, everybody says that ye nahi khana, wo nahi khana, wo. So they cut down. So that's the reason they don't have any. So it's not very difficult to understand why is it that your patient has advanced kidney disease but does not have no edema, urine output continues to be good.
No electrolyte abnormality.
No electrolyte abnormality is till very late. Sodium is good, calcium is good, phosphorus is also not that bad, especially because diet is not very high, so your phosphate intake is not till very advanced stages of kidney disease, your phosphorus is good. So that's because of the adaptations which occur in the kidney in patients of chronic kidney disease. Now, which patients do you think will become edematous? So then, which patient? Vast majority of patients I told you of chronic kidney disease, they come to the ask him, because these are people you don't see as many patients because they stay in the OPD for longer period. The vast majority of our patients don't have much. I see every day, not much of symptoms. And you tell them that your kidney function is good, they don't, क्या हो गया, पागल हो गया, कोई मान नहीं रहा, तो कैसे हो जाएगा, ऐसे कैसे होगा, इतना तो नहीं कम हो सकता. So there is disbelief in them, and that's basically because of the huge adaptations which have occurred. And that's the reason why I wanted a chronic kidney disease patient today. And I thought that this is something you will have to read in between the lines in your books. You will not find it as such. These explanations will have to be thought of. You will have to think about as to the adaptations which occur. You know the adaptations which occur. But to bring about how the clinical manifestations will occur and why is it that your patients are not able to still is basically related to the huge capacity of the kidney. And as I said that you have normal kidneys 50 milliosmoles, 1200 milliosmoles. The capacity of kidney to excrete salt to less than 10 millicoulomns to 300, 400, 500 millicoulomns. Whatever salt you are taking, kidney will excrete it within the next 24, 48 hours. So huge capacity. And as the nephrons go down, these become narrower and narrower. The range becomes narrower until he comes to a very late stage of kidney disease where he has to follow in a very, very narrow lane. If he takes slightly more salt, he can become overhydrated and become volume overloaded. And if he doesn't take, he can suddenly drop his GFR, become severely volume depleted. So a normal person can reduce his salt intake to less than 10 millicoulomns, nothing will happen to him. But a patient of chronic kidney disease, in advanced stages, if he becomes volume depleted, he suddenly has a urea going, creatinine jumping up. So they become severely, because they are natriuretic, it's a salt wasted state. Chronic kidney diseases, salt. They are not able to reduce their sodium intake, sodium excretion to less than 10 millicoulomns. They will not. They will still continue. You give them 10 millicoulomns, they will still continue to excrete 30, 40, 50. So their sodium excretion, fractional excretion of a patient of chronic kidney disease continues to be high. And they are not going to be able to reduce it to that. And you can't take more than 100 millicoulomns of sodium, because then you become volume overloaded, because you are not able to excrete it that large amounts of. So their capacity keeps on going down. So they can trip. So in fact, every patient of chronic kidney disease, you admit them, give them saline, the creatinines and urea will come down. Almost all patients, majority of your patients of chronic kidney disease. But why is it that we don't do it in our day-to-day practice? We tell them to dialysis kar lo, because it's going to be a temporary. You're not going to be. For 1 day, 2 days, they might be able to maintain. You might even show that there is a rise in drop in the creatinine. And this becomes very evident when you do contrast study. So somebody wants to do a coronary angiogram in a patient. The lowest creatinine that you will see in a patient of chronic kidney disease will be when they will be hydrated prior to the contrast. And you will do the creatinine on the day when they are doing the angiogram. His creatinine was 3, now his creatinine is 2.4. ये तो कम हो गई थी उस वक्त. And then as the volume comes back again to normal, the creatinines are back again to that kind of thing. So these are physiological things which you will notice, and you can easily explain to them based on the adaptive things which have happened in a progressively declining nephron mass, which occurs in every patient of chronic kidney disease. The nephrons keep on going down as the kidney disease progresses, be it diabetic kidney disease, be it glomerulonephritis, be it interstitial nephritis. The rate may be slightly different in different diseases. Obviously, diabetic disease progresses much more rapidly in comparison to an interstitial disease, which progresses much less. But obviously related to proteinuria, severity of proteinuria. So where would patients become volume overloaded? We've already talked about it. When you take more salt, if your salt intake is more than what you can excrete, isn't it? So we said that the range is now going down and down, and if your salt intake is more than what you can excrete, then you will become, by and large, our patients, since they follow, Indian patients are more compliant in comparison to Western populations eat larger amounts of volume, large amounts of portions of food as well, and they are bigger eaters as such in comparison to Indians by and large. So you find that you have more salt and water overload in patients in the outside world. But in India, by and large, patients are very, and their family members, because our families are so intertwined with patient care and all that. So usually they don't let them. The wives will never let them. Their husbands have there, and that's the usual complaint. मेरी सुनता नहीं है, ये नहीं करता, वो ये खाता रहता है, ऐसे करता है. So those are the kind of things what our patients usually. So salt consumption is low, and therefore they are not edematous in many of our patients. But whenever the salt intake becomes more, and then what else? If a kidney function drops all of a suddenly, something, you give a drug or something of that sort, and then GFR goes down suddenly, their excretion of salt might fall down quickly. So the fractional excretion of sodium in a normal person, I said that goes to less than 10 if your salt intake is. So if a person is volume depleted, their sodium excretion should be low. Now, which are the patients where sodium excretion or sodium, urinary sodium is still high but they are volume depleted? SIADH में तो urinary sodium is high, but I'm saying which person will have the volume depleted. SIADH patients are not volume depleted. They are actually volume replete. They may not be over edema, but they are volume replete. They are not volume depleted, and urinary sodium is not low, is high.
Diuretics. Patient on diuretics.
No, I'm talking of patients who have volume depleted, but their urinary sodium is not low, is not less than 10. Normal volume depleted person will have a urinary sodium of 10. But which patient will have urinary sodium higher? So somebody who is on diuretics. So obviously they done. If there is an acute kidney injury on top of an acute tubular necrosis on top of it, so or patient is got alkalosis. If the patient is alkalotic, so alkalotic, they will try to excrete bicarbonate, large amounts of bicarbonate. So then bicarbonate के साथ जब जाएगा तो sodium has to be excreted along with it. So they will take sodium along with. So patients who are alkalotic will not have urinary sodium. So that's pathophysiology knitted into. Now we were talking about the free water and the negative free water clearance. What will be negative free water clearance? Let me see now. How much have you understood? What will be negative free water clearance? अरे भाई, osmolar clearance और volume of urine, यही तो चीज़ है ना, volume of urine और osmolar clearance. So negative free water क्या होगा? Free water हो गया positive, negative free water हो गया when osmolar clearance is more than
free water,
than the amount of volume, isn't it?
Yes.
The osmolar clearance is 2 liters, but the total volume of urine passed is about 1 liter. तो 1 liter का negative clearance हो गया. Osmolar clearance होनी चाहिए थी 2 liter, but total volume है ही 1 liter. So 1 liter जो पानी गायब हो गया, वो है which is retained by the body, which is retained by the free water clearance. जब ज़्यादा होगी, positive होगी, urine is dilute. When free water clearance is negative,
the urine will be concentrated.
Urine is concentrated, isn't it? समझ आ गई नहीं आई? Is it? The free water clearance and the negative free water clearance, osmolar clearance and the volume of urine, and the compensation which occurs. Where is the any other area where this, we were talking about the sodium, potassium, natriuresis and others. Where does compensation occur or adaptation occur? This was adaptive natriuresis or solute diuresis which occurs in patients of progressive decline in kidney function because of the single nephron glomerular filtration. Where does any other system where adaptation occurs very, very effectively and starts very early in chronic kidney disease, which you read every day. I'm sure you read it, but I want to say किसका idea आता है? Adaptive chronic kidney disease. हाँ? Yes? बोलने में कोई गर्व नहीं है. गलती में इस वक्त गलती कर लो, जब पेशेंट के साथ होगे फिर गलती माफ नहीं होने वाली. कार्डियोवास्कुलर रीमॉडलिंग तो अलग हो गई. एनीवन एल्स? अरे बोन डिजीज भाई, isn't it? Bone disease is also very, very adaptive kind of a thing. When does parathormone or FGF23 go high? What level of GFR? Huh? Yeah, around 60-70 GFR. The PTH is high. And the PTH is high because of what?
Low GFR,
Hyperphosphatemia.
Hyperphosphatemia due to increased FGF23.
हाँ नहीं, but when you look at serum phosphorus तो normal होता है. At 70 GFR तो normal है. At 50 GFR also normal है. तुम पूछो डॉक्टर साहब से, कभी देखा है इन्होंने 50 GFR, 60 GFR, 70 GFR? phosphorus नहीं आया होता. Serum phosphorus is normal, so hyperphosphatemia तो नहीं है. तो कहाँ पे phosphorus कहाँ पे important है? Phosphorus, अगर आप, if you look at serum, hyperphosphatemia is that the serum phosphorus goes down. The serum phosphorus नहीं आया. So serum phosphorus normal है. So serum phosphorus, when you look at patients of kidney disease, especially in Indian country, बहुत late high होने लगता है, क्योंकि हमारे डाइट में भी नहीं है ऐसा. तो even in GFRs of 30-40 is
Negative feedback of cancer trial. Negative feedback of cancer trial on PTH receptors decreases.
हाँ नहीं, these are multiple things which cause, but I am talking about CKD starting early. 60-70 जब GFR है, जिस वक्त इवन क्रिएटिनिन 1.3 होगी, उस वक्त क्रिएटिनिन भी इतनी ज़्यादा नहीं होगी. GFR 70, 1.3, 1.4 क्रिएटिनिन, GFR भी नॉर्मल ही होगा. एक्चुअली वो क्रिएटिनिन भी नॉर्मल रेंज में ही होगी. 50% के बाद ही क्रिएटिनिन, GFR जब कम होता है तो उसके बाद ही क्रिएटिनिन दिखती है, कुछ ऊंचा जाती है. So it is related to. So what happens when kidney function goes down? To phosphorus and other things? Excretion as such?
phosphorus excretion decreased.
Urinary excretion of phosphorus is
Decreased.
increased. Because of what?
Phosphaturic.
Reabsorption is affected.
तो कम होती है कि एक्सक्रीशन कम होती है कि?
Excretion कम होती है.
जब GFR कम हो जाएगा तो एक्सक्रीशन बढ़ेगी, कम हो जाएगी? कम हो जाएगी. जब phosphorus का excretion, and phosphorus is excreted predominantly from the kidneys. So when phosphorus is excreted from the kidney, so what happens? तो ये कहाँ जाता है phosphorus?
Binds with calcium.
Yeah, binds with calcium. So it's there in the cells. Intracellular phosphorus goes up. In fact, serum phosphorus इतना ज़्यादा नहीं है होता है, तो intracellular phosphorus goes up, and that's where the conversion of vitamin D to active vitamin D and all which occurs in the kidney is related to. So it is intracellular phosphorus which goes up, and that is what prevents the conversion of vitamin D into active vitamin D, and that is what causes rise in the FGF23 and PTH, and then PTH tries to increase the phosphorus excretion and tries to cut it out. So there is a loop, a vicious loop which is set up. So the phosphorus is retained, isn't it? Phosphorus is retained intracellular. Vitamin D conversion doesn't occur. Therefore, calcium absorption from the gut doesn't occur, and hypocalcemia develops, and then PTH again. So there is a direct calcium receptors in the parathyroid. There phosphorus directly also in the parathyroid. So all these mechanisms would cause continuous increase in the PTH, and increased PTH levels cause decrease in the phosphorus. Don't allow the phosphorus to go up. So you have normal phosphorus. Calcium also remains reasonably okay at the price of a higher PTH and FGF23. So unless you measure PTH and FG23, you may not find that the phosphorus is high and all, because this loop tries to excrete the phosphorus itself. Intracellular phosphorus is on the higher side, which is where it is retained, and this continues till the GFR goes down significantly lower. When it comes down to 20, 30, 40, that is when you start seeing phosphorus. So who is the guy who looked at this phosphorus and kidney disease in a Zlatopolsky? Let me tell you, Zlatopolsky. He's no more now, he died about 2 years back. Very elegant experiment. In rabbits, he progressively produced kidney disease in rabbits with progressive knocking off nephrons, okay, in the experimental level. But he kept the phosphorus levels, didn't allow the phosphorus levels to go up at all. So reduced these phosphorus levels to an extent that they were compatible with that GFR, didn't allow. PTH didn't go up. Tremendously elegant experiments that he kept the phosphorus levels maintained, PTH didn't go up. So which was the best kind of a proof that actually it is the phosphorus which is the initial thing which happens, and phosphorus excretion is extremely dependent on the kidney function, the GFR. So as the GFR goes down, the phosphorus excretion goes down, the phosphorus is retained in the body, it gets into the intracellular compartment in the tubules itself, wherever the 25-dihydroxy vitamin D is formed, and that's where it is affected. So extremely good experiment, very elegant. So didn't allow the phosphorus to go up at all, and the PTH didn't go up, the FGF23 didn't go up. When he did the experiments, the FGF23 was not known at that point of time, but later on it was shown that actually FGF23 also goes up if you don't allow the phosphorus. So phosphorus becomes an extremely important ion in that, but patients with chronic kidney disease are able to again adapt at a level of, that's why PTH levels progressively go up as the GFR goes down. But it is modulated by obviously vitamin D, how much of vitamin D a person is taking, that might modify the serum PTH levels, but overall the PTH otherwise goes up. At a high level of PTH, your phosphorus and sodium. So that's another adaptation which a patient of chronic kidney disease is able to do and doesn't allow. So it's a trade-off of maintaining phosphorus and calcium in normal range, and that's what you see in the patients, but at a price when PTH is slightly on the higher side. And that's why PTH, what is the normal PTH in patients of chronic kidney disease?
7 to 8 times.
That's advanced kidney disease. Advanced kidney disease in patients on dialysis, for example. So it may be very high. So what is bad? Low PTH or high PTH? Low PTH. Why is low PTH bad?
Leads to dynamic bone disease.
What is wrong with aerodynamic bone disease? What's wrong with aerodynamic bone disease?
Bone turnover.
मुझे बोलो, मुझे सुनाई कम देता कुछ।
Bone turnover and remodeling effort.
नहीं, उससे क्या हुआ यार, मरीज को क्या होगा? उससे मरीज को क्या होगा? ये तो फ्रैक्चर हो गया, बट फ्रैक्चर तो PTH भी हाई होगा तो उसमें भी फ्रैक्चर होगा। नहीं, but उससे मरीज में क्या फर्क पड़ा? Why is low PTH bad?
Calcium homeostasis is not to be maintained.
उससे कहाँ जाता कैल्शियम? Yeah, vascular calcium. So whatever calcium you give to a person who is got low PTH, it goes into the blood vessels, and that is the cause of very high cardiovascular mortality in patients of dialysis as well as in patients. A 25-year-old patient on dialysis is equivalent to an 80-year-old person. Dies huge. 100 to 1,000 times higher chances of dying on dialysis is because of this. So adynamic bone disease would be. So what kind of PTH would you want at least in your patients on dialysis? So when would you get worried? So something like 200 and less. Don't get to level. So 200, 300. So don't treat 300, 400. You don't need to give vitamin D. Tell about vitamin D की तभी ज़रूरत है कि रोकेल्ट्रॉल और कैल्सिट्रॉल की तभी ज़रूरत है कि जब PTH 500-600 से ऊपर चला जाए. So because otherwise when you give it, your PTH goes down too. So I would be really worried in PTH. So what are the things you will do when the PTH is low?
Avoid calcium supplements. Avoid the calcium supplements.
Yeah, one is you remove vitamin D and calcium supplements and all that. Okay, so you lower the calcium load in the
Non-calcium phosphate binders.
okay, non-calcium phosphate binders, especially, yeah, they're bad in adynamic bone disease. Yes, low PTH. What else? But उससे भी कुछ हो नहीं रहा, फिर क्या करोगे? नहीं, सिनाकैल्सिट तो भैया ऐसे.
की तरह काम करता है.
What else? So what is the calcium in the dialysis? What is the calcium concentration in the dialysis? 1.75. 1.25 तो नहीं है. 1.75. So what you can do is do a low calcium. Actually, that's the good way to get to these PTH patients on a higher. And in fact, when you reduce, you can see the PTH coming back. Your dialysis units, people who are on low PTH, their PTH starts going back up, and it's good to get your patients back into. So PTH, don't lower PTH too much, and don't give unnecessary vitamin D and calcium supplements without doing PTH in a patient of chronic kidney disease. And even so, do it once in 3-6 months. Do PTH regularly, even in early stages of chronic kidney disease, because calcium and adaptive metabolism and all the changes which occur in patients of chronic kidney disease are related to this adaptive mechanism. So today, predominantly my interest was to talk to you about this adaptive things which occur in a patient of chronic kidney disease, and they are very, very closely linked to the patient that you see in the clinic. Actually, it is not that this is physiology or pathophysiology which manifests in the symptoms of the kidney and explains why is it that the patient is not symptomatic advanced. Because it has been fascinating for me to see, sort of look at that patients come with fairly advanced disease but don't have much manifestation. They don't believe you also when you tell them that your kidney function is, and that's related to. So you have to explain as to why is it that patients have not much of symptoms. And the kidney is amazing from that perspective. The adaptations which occur in the kidney to maintain this. The other thing which is again is acid base, which is maintained. Otherwise kidney is also involved in acid base and all that. So that's another whole story of adaptations which occur in the kidney, by which a lot of they will be in metabolic acidosis. So every patient of chronic kidney disease, if you do an ABG in a moderate degree of, they will have acidosis, metabolic acidosis. They may be compensated metabolic, but they will be metabolic acidosis in vast majority of patients of chronic kidney disease. But they are again compensated to a fairly large extent. And in the kidney also, the intrarenal mechanisms of acid-base adaptations are extremely helpful in maintaining these patients into a balance till very advanced stages. Sometimes drugs or other diseases might counterbalance it, and that's cardiovascular disease as one, heart failure, which occurs in patients of chronic kidney, some patients of chronic kidney disease, or there is an inherent ischemic heart disease or something, and that that will alter this compensation to a fairly large extent, because there are episodes of acute kidney injury which occur in patients of heart failure and all. So that's what will happen in many of these patients. So that's what would happen. जी आप भी, मैंने तो एक्चुअली आज क्लास इनकी कुछ डिफरेंट डायरेक्शंस में कर दी थी.
So that's a lot of physiology, and we all get to learn from Professor Kher always a lot of physiology of CKD. So just define CKD for me.
So chronic, as per the KDIGO, chronic kidney disease is a structural or functional damage in the kidney.
So is the KDIGO or is it KDOKI who gave the definition of CKD?
Andy.
So the definition comes from KDOKI. Go on.
So structural or functional damage in the kidney for more than 3 months with implications for health, the with or without the cause of the kidney.
Anybody wants to redefine CKD?
EGFR less than 60.
Give me a proper definition of CKD. Like you're going to define in your exam. Somebody asks you what's the definition of CKD, you're a nephrologist. Your first question is, how will you define CKD?
So structural and functional abnormality in kidney which occurs over this period of more than 3 months. That can include dyslipidemia.
3 months or more.
3 months or more. That can include dyslipidemia, proteinuria, structural.
So there is functional. What is the functional? What is the structural? And what is the radiological?
The structure, the size of the kidney.
Size and appearance of the kidney.
Number of kidney, of course.
Size and appearance of the kidney.
And transplant kidney is also one of them, included in that. Apart from
It's
that,
not there in a definition. I'm asking you the definition which is mentioned in the textbook.
so proteinuria.
So you have structural, you have functional. In functional, you will have protein excretion in the urine. What else?
EGFR.
It's to do with electrolytes.
Yeah, electrolytes, etc.
So electrolyte abnormalities, acid-base abnormalities. Radiological?
Increased echogenicity and loss of carbon.
Altered radiological features.
Increased echogenicity and
Increased
loss of
echogenicity.
corticomedullary.
And what is the other definition of CKD apart from this? Just GFR based?
So it has
Less than 60?
So it has been divided into 5
No, what's less than 60 what?
surface area per.
For 3 or more months. So now the question is that where is this 60 ml come from? Why can't it be 50? Why can't it be 40? Why can't it be 65? Why does the CKD definition have 60 ml? So there has to be reason, like Kher sir has told us, that it's all mathematics and everything explained very simply. And it's not that somebody just comes up with a figure of 60 and becomes 60. There has to be reason for it. Anybody wants to answer? So have you heard of something called as the National Kidney Foundation? What is the National Kidney Foundation? So the National Kidney Foundation is something like the Indian Society of Nephrology for this country. So the National Kidney Foundation lays most of the guidelines for most of the diseases which are related to kidney disorders. And the National Kidney Foundation has laid a GFR of 60 mils or less because there's been large epidemiological data now that as your GFR goes below 60 or stuck at 60 for 3 months or more, you have a rising incidence of cardiovascular diseases, complications of kidney disease such as anemia, metabolic bone disease, and mortality. So 60 is that cutoff. So it's important for us to understand that. So when we are talking of chronic kidney disease, there are 2 different types of chronic kidney disease broadly. One is the glomerular disease and one is the interstitial disease. Now, how will you differentiate between the two when you're looking at a patient, talking to a patient, examining a patient?
So if a patient is presented with a complaint of swelling through the urine and he is also being hypertensive, then we can suspect there is an involvement of glomerular.
Okay. What else?
On urine analysis, we will find active urinary sediments if we are looking for the glomerular pathology.
So you'll find some sediments. They could either be proteinuria, it could be RBC cast.
RBCs.
Okay, so that's glomerular. So how do you differentiate on history when the patient comes to you? Is first is swelling and then is hypertension, and how would you differentiate the other person? He has no swelling and he has no hypertension. And what else is the difference?
Disproportionate amount.
So anemia more in chronic interstitial nephritis. What else?
Urine output.
So almost preserved urine output. Almost preserved urine output.
Hypertension is not there.
The blood pressure is almost normal. Almost normal in most of the cases. What else?
Metabolic bone disease.
Metabolic bone
More
disease.
pronounced in.
So these are things that you have to rattle out in just one go when the differentiation takes place. So now, if I was to ask you that we have discussed so much about diuresis using solute, and what is urea diuresis? You have your patients who are with chronic kidney disease, they have high urea concentration, right? So what is urea diuresis? So is urea an osmotic or a non-osmotic agent? It's an osmotic agent. So ideally speaking, if the urea goes up, it should cause diuresis, right? So if you have a patient who has a glomerular disease, and like you said that the urine output in the glomerular disease patient comes down, the urea is high, then why does the urine output come down despite having such a high urea?
Because it can cross, it is highly permeable. So it can, along with that, fluid or water is also retained. So
Yeah, so if you have a patient who has a glomerular disease, it's basically the fluid is always retained into the extravascular compartment. Very less of it is in the intravascular compartment. So despite having urea much higher, you're not going to have diuresis. So then where do you find urea diuresis?
post-renal transplant. Polyuric
Yeah.
phase of AKI.
So the first thing is the transplant patient, just on day 1, day 2, day 3, you'll have a lot of diuresis, urea diuresis. Number 2?
Polyuric phase of AKI, sir. In 3 phases of AKI, last phase that we can.
No, it's generally not. It's not the reason for the polyuria there. What else? Very commonly you see, you go in the round in the morning and you'll just see a reference and then you'll see that lot of urine passing in that patient. And so you're seeing patients with hypernatremia. What happens to their urine? Patients with hypernatremia. So when you go to the ICU, don't you find patients over there who have high catabolic rates, who have sepsis, and still the urine output is very high? So these are patients who have very high urea load. When you look at their ureas are much higher than their creatinine. So these are patients who have urea diuresis. Now a little bit about nocturia. So how would you differentiate between a patient who comes to you with some kind of a kidney disease versus somebody who has an enlarged prostate? So both of them are going to have some kind of a urinary disturbance at night. So what is the differentiating point between the two?
We will have voiding symptoms.
So they will have persistent lower urinary tract symptom. What else? I'm specifically talking about night urine, not talking about day urine.
Sensation of incomplete voiding will be there.
What else? That is a persistent symptom, but what else?
Yes.
And there are some prostatic disorders which will not have that feeling, they will not have that feeling of incomplete voiding. So nocuria is basically a disorder of volume. So when you're passing large volumes, like sir has already told you, when you pass large volumes in the ratio of 2/3, that is if you divide the entire day into 3 parts and you're passing 2/3 at night in terms of volume, not in terms of frequency, then that is called as nocturia. And that is very typical of nocturia in CKD patients. In mineral bone disorder that we've discussed, which is the first molecule that you see that tends to go up? FGF. Anything else that tends to be altered, which is even earlier than the clotho? What is clotho? There's a short note on clotho. What is clotho?
That is receptor for the
So what happens to clotho?
decrease, so FGF will not work with the receptors.
So that's the breaking point, that nothing happens to clotho actually. It's a down regulation of clotho receptors, which does not help the FGF to bind to clotho. So the FGF levels go up, the clotho stays same. But because the FGF goes high, the clotho in proportion tends to get lower.
In this, coming back to your patient, let's talk about the patient as well now. So this is a patient who's got diabetic nephropathy,
Yes.
isn't it? So you said that this patient had diabetic retinopathy also.
Yes, sir.
So do you look at patients with their own retina ever? Have you, किसी ने किया कभी retina examination? आजकल तो मेरे ख्याल में कोई करता भी नहीं है शायद, current scenario में. So you wouldn't have seen a patient with diabetic retinopathy yourself. Have you, somebody who comes with, but आपके पास तो ऑप्थेल्मोस्कोप भी नहीं होगा, देखेंगे कैसे? उसमें हॉस्पिटल्स में तो होता होगा, वार्ड्स में do they keep, I think?
Yeah, they generally do it before their exams, sir. About
They do it
15 days before exam, they go to the ophthalmologist.
they go to the ophthalmologist and that's why they do it?
That's why they do it.
अच्छा.
The ones who don't do it will be told to do it in the exam.
अच्छा. हाँ नहीं, but no, I was wanting to find out as to how would you classify diabetic retinopathy.
Sir,
Theory में तो पढ़े होगी, but it's good to see these. So, and sometimes you may get a picture, and then if you haven't seen one, then you wouldn't know what it is. Anyway, classify.
Sir, diabetic retinopathy is classified into non-proliferative and proliferative diabetic retinopathy. In non-proliferative class 1, there will be microaneurysmal dilatation. It seems like a small balloon-like swelling. In the class 2, there will be the blockage of the small vessels, and in class 3, there will the blockage is more enhanced and it shows as an ischemic changes over the retina. The class 4 is proliferative diabetic retinopathy, whereas new vascularization will appear.
What about cotton wool exudates? What are they? You heard of them or no?
Yes, sir.
You heard of them. So which part is that? Anyone? What are cotton wool exudates? They're exudates or they're not exudates?
Soft exudates,
They are?
soft exudates.
No, they are infarcts actually, retinal infarcts, right. So they are retinal infarcts. So you will have retinal infarcts in fact actually, which will appear as a cotton wool actually.
She's given the diagnosis.
Fun?
She's given the diagnosis.
Diagnosis तो इसमें diabetic nephropathy because retinopathy was there and all that. But if there wasn't a retinopathy, how will you make a diagnosis of diabetic kidney disease? What percentage of people will have retinopathy along with diabetic?
In type 1 diabetics, more than 90% of the patient will have diabetic retinopathy, while in type 2 diabetic patient, approximately 50 to 60% patient will have diabetic retinopathy.
And what happens to the other? So what will be the disease in the other 50%? This will be diabetic, or you think there could be other diseases as well?
Sir,
So how does?
we need to validate further. We can go with the biopsy to rule out what can be the
So
possible.
where would you do a biopsy? Which patients would you
Sir,
do
if a
biopsy?
patient is having absence of diabetic retinopathy, if a patient is presented with sudden...
So every patient with no retinopathy, you should biopsy?
No sir, other factors we have to look.
So what are the other factors?
If their patient present with active urinary sediment or macrohematuria, then we need to go for the biopsy. If there is
What percentage of diabetic nephropathy may have hematuria? Microscopic
10
hematuria.
to 20%.
Maybe about 10-15%, 20% people might have microscopic hematuria, and they may have no other glomerular disease as such. Okay, so yes, but if there is, what else more important?
Sir, if a patient presented with sudden onset of nephrotic range proteinuria, if the course of patient is not following the natural
History, extremely important. Extremely important. This is the natural history of, although in type 2, this is typical in type 1 nephropathy, type 1 diabetic kidney disease, but in patients with type 2, the onset of type 2 diabetes, one may not be very sure. You may have had long lag period where the diagnosis may not have happened, or the patient may have never known about type 2 disease. So you don't know when did it start. But yes, the natural course of the diabetes is not, if it is sort of atypical, then one should do it. Okay, so what are the diseases that you will consider in patients who have history of diabetes? And so what percentage of people have non-diabetic?
So 25 to 28% of the patient can have
about 25 to 30% of patients with type 2 diabetes may have
non-diabetic related chronic kidney disease.
So what are the non-diabetic kidney diseases?
So there can be secondary FSGS can be there. There can be hypertensive nephrosclerosis. There can be post-immune glomerulonephritis. IgA nephropathy can be there. Membranous nephropathy.
Other glomerular nephritis can be there. Any other disease which?
Test deposit disease can be.
One?
Myeloma.
Yeah, myeloma. Those are other diseases which may be there. In fact, the commonest diagnosis that I have missed in diabetics has been, where I haven't done a biopsy and I've been surprised, has been a myeloma coming later on, when you find that you had missed a myeloma actually. So that's because this is one disease where you don't do biopsies by and large, and this disease you haven't considered because you felt anemia was part of the CKD disease, and then many times you get surprised many years later that they turn out to have multiple myeloma. And so this is one disease where you should look for monoclonal. Keep it always in your mind, because you haven't done a biopsy in these patients. Until you have done a biopsy, you're never sure that this is diabetic. You make a presumptive diagnosis based on natural history. All of them have fallacies, and so therefore you might be surprised. So whenever you have diabetes and you feel that maybe this is not, especially when retinopathy is not there, I would do a monoclonal gammopathy checkup on the blood to be sure that this is a patient, because you missed myeloma in these patients. So that's something in diabetics happens very often in our patients with diabetes, that you find later that this patient had multiple myeloma. So that's another disease that you must be. Obviously, whenever there is a possibility that you need to do a biopsy, then you will do a biopsy in these patients, and you might pick up glomerular disease. Or what are the other areas where diabetes affects kidneys? One is
vascular compartment, tubulointerstitial compartment.
What are the diseases in tubulointerstitial compartment? भाई आप ही ने कहा ट्यूबुलर इंटरस्टिशियल कंपार्टमेंट है, तो कहाँ बताइए डिजीज? एनीवन? Did you look for neuropathy in this patient?
Sir, I asked about the symptoms for the neuropathy.
So you mean if the patient has no symptoms of neuropathy, there may not be any neuropathy?
There must be, sir.
So what are the areas which you think are affected by neuropathy? In what systems would you look for?
So we have to look for peripheral neuropathy or
One is peripheral neuropathy, okay.
autonomic neuropathy can be there in
Pardon?
diabetic
Autonomic neuropathy. So where would autonomic neuropathy act?
So
Where would you?
patient can give like diabetic dystonias can be, the patient will give symptoms of incomplete voiding sensation of bladder.
So bladder symptoms would be definitely in addition to, so bladder symptoms are extremely, GI symptoms another extremely important. What about cardiovascular?
Resting tachycardia, orthostatic hypotension can be there.
So what would be the difference between volume depletion when you check the blood pressure in the lying down and standing, and when you check in a patient with diabetic autonomic neuropathy? So you do check the blood pressure both in the lying down and make him stand. So what will you see?
So if the systolic blood pressure does not rise more than 20 mm of Hg, then it is suggested that patient is having orthostatic hypotension.
No, to define difference between volume depletion. So somebody who is volume depleted, what happens to postural hypotension? Postural blood pressure? It will drop.
Yes.
Okay. So there will be drop of more than 20 जो आप define कर रही थी. So maybe it will happen. But this will happen in diabetic neuropathy also. So what will be the difference? How will you know कि ये diabetes की वजह से है या volume depletion की वजह से? टैकीकार्डिया, किसमें टैकीकार्डिया होगा और नहीं होगा?
So if it is of hypovolemia, then there should be reflex tachycardia.
There would be reflex tachycardia if there isn't. Then in patient with autonomic neuropathy, there may be no reflex tachycardia. So whenever there is drop in blood pressure, and that's important. So in an emergency you go, you see patients with volume depletion, and the nephrologists unfortunately have lost this, not being able to diagnose volume depletion, and I feel sad that and then you give fluid repletion, you give something like 60 ml of water. Now, if you do fluid repletion, then you must give adequate fluid repletion in a volume depleted person. I usually go to the emergencies and find that the nephrology resident has gone and says volume depletion, maybe pre-renal AKI, and then written an order for fluid, normal saline. So would you give normal saline or a dextrose in a patient who is volume depleted?
So normal saline.
Normal saline. Why? Why would you give normal saline? Why not dextrose? I'll say dextrose थोड़ा न्यूट्रिशन भी है, मेरे मरीज को तो खाना पीना भी नहीं होता, थोड़ा शुगर भी मिल जाएगा, डेक्सट्रोज मिल जाएगा, तो why not dextrose? Why give normal saline to a person who is volume? थोड़ा सा calories भी मिल जाएंगी. Our patients are calorie deficient. हाँ जी? Why? Anyone की कौन सा?
High volume distribution.
Pardon?
High volume distribution of dextrose.
Where does dextrose distribute? Huh? Dextrose goes to extracellular compartment. And normal saline?
Will go to extracellular.
Normal saline goes where? Intracellular compartment.
So it would be like free water. And in case of MS, there will be like, sodium will be there and it will try to hold on the water.
Where?
In the intravascular.
Yeah, so in the intravascular. So you want the fluid to remain in the extra. Sodium is a predominantly extracellular fluid and it remains in the extracellular volume. It doesn't go in. And dextrose goes into. So if you give 1 liter of dextrose and you give 1 liter of normal saline, where does after 4 hours, where is this dextrose water gone and where is normal saline gone? 1 liter fluid दिया dextrose, 1 liter fluid दिया, 1 liter of normal saline. So where will it go? Normal saline कहाँ गया? 4 घंटे के बाद देखा आपने, कहाँ है ये normal saline, कहाँ गया?
Extracellular
It remains in the intravascular compartment, and that's the reason why when a patient is hypovolemic, you want to give a solution which remains in the intravascular compartment and it doesn't move in. So it is in sync with the extracellular compartment, so it is there as a part of that, so it remains there. And where would 5% dextrose solution go? How much will remain intravascular, how much will go where?
So it will
ये तो
3/4.
ये अगर नेफ्रोलॉजिस्ट को नहीं आता ना तो ये तो गड़बड़ होती है। ये तो अगर ये तो फिर डॉक्टर मनी का ये फेवरेट सवाल होता था, आई कैन टेल यू। ये कहते थे कि भाई मुझे मालूम है आप डीएम के पास पढ़ के आए हो, सब ब्रनर भी पढ़ के आए हो, बट मुझे ये बताओ ये पानी कहाँ जाएगा? सो how much will remain?
It will be filtered out.
It will be filtered out where? Out of the body? वो तो normal saline भी जाएगा, urine out में तो जाएगा ही ultimately.
Divide according to 1/3 and 2/3. The
Yes.
2/3 will divide, go to the intracellularly and 1/3 to extracellular compartments.
So 1/3 will go into this, so 67% remains inside. So it goes into an intracellular compartment. So a lot of it goes into the intracellular compartment. So water will diffuse into the intracellular because of the osmolar changes that it brings about. And when you give same amount of sodium only without the water also, it will again bring
The
water from the intracellular compartment into the extracellular compartment. So that because of the changes in the osmolarity. So basically the extracellular and water is freely movable. Urea, although it is a solute and it should hold, but because urea diffuses across semi-permeable membranes like along with water, so therefore is not an osmolar, effective osmol nahi hai. So that is the problem with urea usually, because it diffuses across. Otherwise it's an osmotic agent and can be used and all that. So so usually it's very important for people to realize that what fluid to give where, and depending on the losses, especially volume depletion. So it's the loss of the sodium, and volume depletion will be diagnosed by, a nephrologist will diagnose volume depletion by
clinical examination.
नहीं, clinical examination तो हर चीज का है, physician, every physician will, by urinary sodium. If there isn't anything else, the patient is not on urinary sodium. A nephrologist diagnosis of volume depletion will be urinary sodium, because urinary sodium would be
Less.
less. So that's a nephrologist diagnosis of it. Pathophysiology coming into it. The urinary sodium would be low. That will make a diagnosis of it. Clinical diagnosis, obviously, there are various clinical markers of that volume depletion. And what is dehydration? How is volume depletion and dehydration any different? Although they are used interchangeably, that the patient is dehydrated, so some people will say volume depleted. So, but in physiological terms, again, since we are talking today of physiology, pathophysiology, so volume, when you talk of volume, you are talking of extracellular fluid volume. When you talk of dehydration, it's usually a loss of the intracellular volume. And so water deprivation, since water moves across, so whenever water will be in the, you have extracellular volume water depletion, then water will move from the intracellular compartment into this compartment. So there will be deficiency of water. Whenever there is deficiency of water, that's called dehydration, and you need to give predominantly actually. So both lot of water is lost more than the saline loss, then that will be intracellular loss of water. So you will be dehydrated. So in comparison, any questions you have? So I think maybe if there are any pending questions, you should actually come with some pointed questions sometimes may be related to the case, but sometimes you could be even otherwise, that something that you have. So develop a habit of asking questions, and unfortunately I think that's something which is, that's related to what you read, and that should incite questions in your brain. Why does?
He is supposed to get isostonuric urine.
Pardon?
At what EGFR he is supposed to get isostonuric urine?
No, usually as the kidney function starts going down, you start looking at, see, urine, if you do the osmolality of the urine, and urine osmolality goes down. So less than 60 would be where it starts coming down.
The urine osmolality would be around 280.
280, 280. But it can get modified by different things. So you could, depending on the intake of water and other things, can also modify some of these. To some diuretics, drugs might modify it. So those are things which might modify it to some extent, but otherwise, usually as the GFR starts going down, the urine becomes isostonuric, and the changes, adaptive changes start occurring simultaneously. As the number of nephrons goes down, and this becomes narrower and narrower. Obviously it's here to here, so then it starts going down, and then you can't go beyond a particular down. In normal kidney you are almost very close, less than 10 millicrons, 50 milliosmoles, which is almost near to zero, almost close heads. But in CKD you can't go below a particular level. You can't either dilute, late concentration gets affected earlier than dilution. But still, for a long period of time, you will continue to maintain these. And that's what makes kidney so amazing also, is that you have this capacity of adaptiveness. It occurs in many other organs. It's not that kidney is the lone organ in this, but many organs will be able to. But kidney is able to because it's an organ which maintains the milieu interior, the internal environment. So if it wasn't able to do this, then you would have seen that it could have created a havoc earlier, much earlier and all that. And people would come with a lot of symptoms of either hyponatremia, hypernatremia, calcium and phosphorus changes and all that. But because of these adaptive changes which occur related to the homeostasis, related to kidney, you don't see the catastrophic clinical presentations that would otherwise occur. So that's the adaptations which occur in this, and unfortunately the only place where you had a very good explanation on this was by Christopher Blagg, who had written this chapter on adaptations with nephron loss. I think there is an article in New England Journal of Medicine also by Christopher Blagg on that's way back in 70s actually. So, and a lot of this work was done in those times only. Brenner and these people had done this work in the labs itself. And I think first edition of Brenner was the one which had given this chapter. After that, I haven't looked at the recent books or recent editions. I don't know if any one of you even read Brenner, or you may have heard of it, but I don't know. Is it commonly read these days? Not even. You don't even look at it. और कभी नमस्कार तो गीता को कभी हो जाए ना कि देख लो पेजेस का ही. It's like a Bible for nephrologists, but I don't think these days anyone looks at. है भाई ब्रेनर तो कोई नहीं पढ़ता ना. नहीं आज की तारीख में तो भूल गए.
So as my teachers used to tell me that when you have a case of diabetic kidney disease and when you're presenting it, if you want to really pass your exam, you should find features of non-diabetic kidney disease in your patient. For example, you have a diabetic patient, you should not make a direct diagnosis of diabetic kidney disease despite the presence of retinopathy. You should look for features of non-diabetic kidney disease and emphasize that I did look for features of non-diabetic kidney disease, because that is something which will differentiate you from the other candidates. That at least you look for something that could at least reverse or slow down the progression and the rate of fall of eGFR. So that's one thing that you should do. And the second is, when you're taking your history, it's if you can find in your history the first sign of autonomic neuropathy in a female diabetic patient or in a male diabetic patient, that should be put in the history. So what is it that you would look as the first sign of autonomic neuropathy in the history for a male? Because that's where it all starts from. Erectile dysfunction. And what about female? Yes, sexual dysfunction. So these two things should be put in the history. I don't know, I was not there for the history, whether you put it on.
No. I don't think these were put in, but I this time didn't emphasize much on the diagnosis and other things because I had asked her to change the CKD case because she was wanting to present pregnancy, but I thought that this is something which is not discussed or will not be discussed in patients. I feel that patients with chronic kidney disease are something that you will see every day in your clinic, but you will get surprised and you may not be able to, if you haven't thought about it in a fashion of pathophysiological explanations, you may not be able to understand this is. So basically when you start looking at these patients in this fashion and you look at fractional excretion of sodium, you look at are they volume overloaded, volume depleted, is it dehydration, is it volume depletion. So when you start looking at these terms, then you will clinically start asking these questions yourself and you will probably be able to understand it much better. So it's important to read this. The other books that you could read is also acid-base physiology by क्या नाम है भाई उसका जिसका up to date था the guy नहीं forget he was in Beth Israel, I forget his name. So that book is also extremely useful book. It tells you about how physiology manifests or pathophysiology manifests in disease. So clinical correlation every day that you see in the clinic, and then you start understanding how do you apply it as a nephrologist to the patient. That's why I said that volume depletion you might physically examine it, but for a nephrologist, urinary sodium would be the thing. That will tell you that it is volume depleted or not depleted. Urinary sodium would be the thing. And if you want to see patient is volume overloaded, then do the urinary sodium. Extracellular volume is the thing that will tell you extracellular volume would be the urinary sodium. If it is high urinary sodium, you know that extracellular volume is. But these may be modified in the clinical, and how these get modified by drugs, by diseases and other things would be what will change it. So if you understand this basic, then you will be able to apply it in how heart failure changes it. How would a particular drug, how would a diuretic change this? And then you will be able to apply this into a diuresis and those kind of things. So that is why this I thought was important. So that's why I asked you to change your. I thought that you will actually diabetic kidney disease is, although chronic kidney disease, but then diabetic kidney disease is a different. While we are a diabetic kidney disease, what is the difference between diabetic kidney disease and diabetic nephropathy?
So diabetic kidney disease is an umbrella term which include all the kidney disease. And diabetic nephropathy specifically when the glomeruli are affected and patient having a proteinuria of more albuminuria.
Proteinuria. A typical diabetic nephropathy would be something which will be microalbuminuria, then albuminuria. The natural history is more of an albuminuric. But then there are non-albuminuric kidney diseases as well which occur in diabetes and that could be related also to diabetes. So yes, it's a broader umbrella of any kidney disease occurring in a diabetic could be a diabetic kidney disease, which would include also diabetic nephropathy, which is the typical natural history which is usually derived from type 1 diabetic kidney disease, but is also true for type 2 diabetic kidney disease. They're not very different from that perspective. Yes.
Another last point I would say is that always quote Indian data. So when you're asking, when you're asked about non-diabetic kidney disease, you should quote Indian data. So the incidence of non-diabetic kidney disease in our country has just been published last year, 2024, by CPGI, and it's as high as 49%. So it's a very high, and the highest reason for non-diabetic kidney disease, which is biopsy based, is acute interstitial nephritis, one of the highest causes. So that is surprising. So all of this data should be quoted in exam, not just textbook. Because if we quote the textbook is all Western, and now by God's grace, I think we have enough data for almost all the diseases in this country.
Interstitial disease is fairly high in our country, and this was even when you did biopsies or didn't do biopsies, but multiple, when you look at unknown causes of kidney disease, and many of them would be interstitial, whether you look at the chronic kidney disease data from everywhere. And when you do biopsies also, you'll find interstitial disease, even in glomerular disease, fairly high evidence of interstitial, more than what is explained by glomerular. And that's related to the toxins that we have, be it water toxins, be it pollution, be it drugs. The amount of drugs that Indians take and physicians give is huge. So all these drugs, even though they may be believed to be not nephrotoxic and all that, will produce. All the drugs are excreted through the kidneys, and everything can be, if they're not doing any good, many times you keep on giving many drugs. People also keep on loving to take all kind of medicines. All of them are excreted. So nephrotoxic or non-nephrotoxic drugs. So they will all be incriminated as drugs which could have potentially caused chemical toxicity and interstitial nephritis. So incidence of interstitial nephritis in any publications in Indian data is going to be very high. So we have unknown kidney disease, which one is CKD-U, which is a different kind of thing. But unknown kidney disease in the regular kind of a setup also is about 20% to 30%, where we don't know the cause of kidney disease. So that's fairly high CKD as well. So unknown kidney disease is fairly high, and that's, a lot of it is related to the toxicities related to chemicals and water toxicity, the toxins in our earth, toxins in our food, toxins in the environment, and all of that is producing kidney disease in our country. And that's one of the reasons why we have higher incidence of CKD relatively in our countries. In the low income group countries, the incidence is higher, is related to a lot of other diseases than the common garden variety of kidney diseases that we see, glomerular disease, diabetes, and all. So those are very. Chalo ji, thank you.
Thank you, sir.
Thank you ji.